Hello friends, today we will learn how to insert indwelling pleural catheter in case of recurrent pleural effusion. I will show you this technique in live patient. I will do this procedure in live patient so that you can understand in every steps of this procedure. Okay. So before proceeding to this procedure, I will discuss some basic things. First, indication, when to insert, which patient we have to insert this pleural catheter. Okay. So main indication is recurrent pleural effusion when primary etiology is not correctable, like malignant pleural effusion. So as you know, in malignancy there is recurrent pleural effusion and patient need to be aspirated repeatedly. So to avoid recurrent pleural aspiration or thoracocentesis, we can insert this indwelling pleural catheter, especially when patient is having trapped lung. Okay. Another indication is benign condition, not benign condition like a hepatic hydrothorax when liver cirrhosis is not correctable. So there is recurrent pleural effusion in hepatic hydrothorax, so we can insert IPC in them also. Pleural effusion secondary to congestive heart failure, pleural effusion secondary to chronic kidney disease where patient is on dialysis and still patient is having recurrent pleural effusion. Such type of patient we can consider for IPC. Contraindication is same for any other procedure of chest tube like uncorrectable coagulopathy, active infection, low platelet count, same as other procedures. So how this looks like is, so in this diagram you can see there is bottle number 1 and another thing is catheter. Okay. If you see carefully this catheter, I have marked 2, 3, 4, 5. If you see 2, this is the end of IPC. IPC is indwelling pleural catheter. So one is the valve, it has one-way valve, means pleural effusion can come out but air cannot suck inside the pleural cavity. So it has unique feature, that is one-way valve. Number 3, you can see there is white color, a raised part, that is polyester cuff, is a cuff, Dacron cuff or polyester cuff. So this is used, I will show you in procedure, but this is to be kept inside the skin. Okay. And its primary function is to fix the chest tube or fix the IPC, because IPC to be kept for long time. So to prevent dislodge of this IPC, this polyester cuff helps. Second function is to prevent infection, because it doesn't allow to spread infection from subcutaneous tissue to inside the pleural cavity. So it has two functions. Number 4 and number 5, you can see many fenestrations are there, many holes are there. So if any or 2 or 3 fenestrations get blocks, other functions, other fenestration will work and will drain the pleural effusion. That's why it has multiple fenestration. This tube is made up of silicone, soft silicone. So soft silicone is comfortable for patient, is less painful and it helps in autopleurodesis. Number 1, you can see there is drainage bottle. Okay. Bottle is capacity is around 1 liter and you can see the top of bottle there is some white color cap. Once you insert that white color some cap, there will be creation of negative pressure. So by pressing this cap, this bottle will be having negative pressure. So by negative pressure, it will suck pleural fluid from pleural cavity. So once you will put IPC, you will connect this drainage bottle. The drainage bottle will suck pleural fluid. Because what happens in normal chest tube? In normal chest tube, you are that connecting water sealed bag. It doesn't have any negative pressure. So pleural fluid will come by gravity only. Okay. But in this system, pleural fluid will come by gravity as well as with negative pressure, which is being created in this bottle, drainage bottle. So these are the item which is there in kit. Once you purchase that IPC kit or in that brand name is Plurex, so they will give, these are the item which will help in insertion of IPC. So in this you can see the top is the top right corner, it is connector. It will connect IPC with bottle, and you can see there is stopper also there. Okay, stoppers looks like same as you seen in IV drip. Once you that scroll up, it will get closed. Once you scroll down, it will get open. In right below, you can see the metallic needle like or trocar. So how to use trocar I will show you in procedure, but it is helpful to insert IPC inside the skin or subcutaneous plane. Just beside this metal trocar, you can see needle with sheath. It is same as used in while inserting that central line or percutaneous tracheostomy. And third thing is, you can see this green color. This is a peel away sheath. How to use I will show you in procedure. And inside this peel away sheath, white color, you can see this is dilator, same as used in central line. Once you insert, it will dilate the tract. Then you can see left lower corner, this is guide wire, which will help to insert needle. Then of course syringe is there, and you can see left upper corner, this is dressing material. So along with kit, this dressing material also come, which is completely sterile. So these are the component which is there in insertion kit. So how to use I will show you in live procedure. Now you will ask me question, how IPC is better or how IPC is benefit over pigtail or intercostal tube drainage. So first benefit is there is less chance of infection, because we know that we are going to keep IPC for long time. So to prevent it, with IPC there is less chance of infection like empyema. Another is that bottle, drainage bottle is having negative pressure, it will suck out pleural fluid. Another thing is that IPCs also have one way valve, because you know that we are going to keep for long time, and by mistaken patient disconnected this tube, the air will suck out in case of pigtail or ICD. But in this IPC there is one way valve, so air cannot insert inside the pleural cavity, and around 30 to 50% patient they are going for autopleurodesis spontaneously. Autopleurodesis means visceral pleura and pedal pleura will stick together, and there will be no pleural effusion formation. So this is advantage of IPC, but the problem is cost. Its cost is around 40,000 in India. Right now come to OT, and I will show you demonstration in live patient. So come to OT. So this is our patient, a 70-year-old male with known case of lung carcinoma, is having left side recurrent pleural effusion, and this is the IPC set, which has catheter and 4 bottles along with all accessories. We will arrange all things in a sterile dressing trolley. We will clean it by sterlium, betadine sterlium. We will take sterile draw sheet, and we will mark our surgical site. So we have marked our IPC site in ultrasound. So you can see this is our site, and above this site around 3 breath or 4 to 5 centimeter above we will mark again, and this is for our IPC site. We will take 1% lignocaine, we will give lignocaine as we are giving in ICD. So layer by layer, once we will reach insert the pleural cavity, we will suck out and confirm our diagnosis. We will give local in that site also. This is IPC site, and we will give local in subcutaneous plane only, because we are not going to puncture pleura here. So we will give subcutaneous tissue, and we will also give in tract side, because we are going to insert the trocar. I will show you. So we will give local in that direction also. So we will give local in that direction and through in subcutaneous plane, because we are going to insert our IPC from this side only. So it should be sterilized or it should be anesthetized properly. So we will take 11 number blade, and we will mark 0.5 subcutaneous incision, only subcutaneous incision. Then we will take needle along with sheath with syringe, as we are inserting in central line. So we will insert. Once you feel that pleura, you will suck out, and you can see pleural fluid. So our site is correct. Now we will remove needle and we will keep sheath inside. Now we'll take guide wire, and this is same guide wire. The tip is rounded, so it should not cause injury to pleura. So we'll insert guide wire like in central line. So guide wire should go freely, it should not stuck anywhere, and it will not cause harm to pleura. So once we will insert guide wire, we will remove that sheath. We will remove, this is sheath, yes. So after removing sheath, we will give small incision on IPC side, that is second side, and it is small, 0.3 centimeter. Just we have to insert IPC only, so small incision, that is skin incision only. Now we will take IPC along with trocar. So you can see this is trocar which is attached to IPC. It's like a needle and thread which we are using in childhood. So we will insert subcutaneously and we will try to pass, and we will to insert and will come out from previous incision. So we have to push hard, then only it will come out. We have to push hard. Yes, it came out. So incision is very small, so we have to give force, we have to pull strongly so that it should not get stuck inside the subcutaneous tissue. So we have to pull up to the Dacron cuff. So this is white color is Dacron cuff. So we will pull hard to insert Dacron cuff inside subcutaneous plane. We have to push hard. So if it is too hard, we can give small incision also, but it gone inside, so no problem. And it should be in the middle part, so we can adjust by pulling or pushing. So it should be in middle part. So now this is our correct position. So this is guide wire. Now we will take our dilator along with breakable sheath. We can remove trocar. So this is dilator inside, and outside this is breakable sheath, this green color, the breakable sheath. So I'll show you how to insert. So we have to insert through guide wire inside the pleural cavity, but incision is small, so it's not going. So what we will do, we'll take 11 number blade again and we'll give subcutaneous incision, just 0.1 to 0.2 mm only, just subcutaneous incision, not deeper incision. So we have to push it by keeping our thumb on top of that. So we have to push it, and once you will feel free, it means it is pleural cavity. So we will take one syringe and we will suck out to confirm our diagnosis or our site of insertion. So this is pleural fluid. So it means that our dilator and sheath in correct position. So after removing this dilator, we will insert our IPC inside the sheath, breakable sheath. So gently we have to push it, and it should go freely. There are multiple fenestration. Make sure all fenestration should be inside the pleural cavity. So yes, now this green part we will break it like this. Yes. Now we will pull out. Once we will pull out, we will insert IPC inside. We are gently breaking this sheath, removing outside and pushing tube inside. So now sheath is outside. So now our IPC is inside the pleural cavity. So we have given 1 milligram midazolam and 100 microgram of fentanyl, conscious sedation, because this is painful procedure. So we'll give 2 skin suture like any other cut. So 2 suture. So it is painful, so we have to use conscious sedation along with 1% lignocaine as local infiltration. Patient is very cooperative. So this is two suture we have given. Now we will fix IPC like any other chest tube. So first we will give suture to subcutaneous tissue, and after that we will fix chest tube by tying IPC with this suture. So this is skin suture we are giving. So this is simple procedure, but the thing is costly procedure. That's why it's not being done many in our patients, especially poor patients. Otherwise it is good procedure. This is useful for patient. So after giving skin suture, we will tie this IPC with this thread only, this suture only. So it is fixed. Actually our IPC is fixed with the Dacron cuff, which is there inside the skin and subcutaneous tissue. And by tying this IPC, we are keeping again fixed. So this is how we have to insert our IPC. So this is bottle along with connector, and you can see this is like a stopper, like a IV set. Once you push down, it will get close. Pull down, pull up is up. So we'll insert this tube to a one-way valve, and you will heard click sound. Once you heard click sound, you have to remove bottle stopper, and you have to press hard this cap, white color. You have to push hard. So it will break the seal and it will create negative pressure. So now bottle is having negative pressure. Now you have to open by pushing upward, and you can see this pleural fluid which is draining inside the bottle. So in bottle, because of negative pressure, it is pulling pleural fluid inside the bottle from pleural cavity. So for dressing, we have to close this by pushing below like any IV set. Then only we have to connect. So remember thing that we should not disconnect without closing the IPC, and this is the sterile cap. We can then apply cap to this IPC. So we have to clean side and we have to do dressing. So dressing material comes in the package, in the kit. So this is gauze pad which is there along with the kit, and above gauze pad we have to fold this IPC, and ideally whole IPC should be inside the dressing. But this is practically difficult for patient to remove dressing every time for draining. So we are keeping the end of IPC outside the dressing. So you can see the end of IPC is outside the dressing. We are keeping gauze paste, and along above gauze pad there is transparent dressing, transparent tape. So we have to stick this transparent tape, and we have to keep end of IPC outside, so that it is easy for patient to drain whenever he want to drain pleural fluid. So after sting, we have to remove this white part. So inside white part there is transparent dressing. So this is easy procedure. Ideally this end of IPC should be inside the dressing, and every time when patient is draining pleural fluid, dressing has to be changed, but this is not practically possible every time. So we are keeping end outside. So we will open the cap and we will connect again our bottle. So we'll open again, and this is that, and you will heard click sound. So click, it means that connector is connecting. Now we will open by our stopper like any IV set. We'll open it, and you can see. So this is our IV, this is our connector. So you can see pleural fluid is coming out, and it is because of negative pressure as well as gravity. So fluid is draining out. This is how we have to do our IPC procedure. Now our IPC procedure has been completed. This is our intervention team. Along with me, my professor Ajay Kumar Verma is there, SR Sagar Jain, Kanak Verma is there, staff Manish and Pinky is there. And this is the post procedure X-ray. You can see IPC in left side in this X-ray. So friends, I hope you have learned many things from this video. So one thing I would like to tell you that these bottles are costly affair, because in one kit there are 4 bottles only, and I must tell you that one bottle we can use one time only. Once one bottle filled with 1 liter of pleural fluid, we cannot use again this bottle. Okay, why? Because this bottle is having negative pressure. Once you open the bottle, negative pressure will go off, right? Once you attach this bottle again, there will be no negative pressure, and the air inside the bottle will be sucked out inside the pleural cavity. So you will create pneumothorax, iatrogenic pneumothorax. So one bottle can be used one time only, we cannot use again and again, right? So if patient is poor, and as I told you that one kit 4 bottles are there, if all 4 bottles are utilized and patient is not affordable, because one bottle is cost around 2000 rupees. If patient is not affordable, we can use water seal drainage bag, which is being commonly used with intercostal tube drainage or pectoral catheter. Okay, the only problem is that it doesn't have negative pressure. So pleural fluid will come by gravity only. So if you like this video, please like it, share with your friends, and if you have any suggestion or any comment or any doubt, please write in comment box. See you with another video. Thank you very much.